really pleased to introduce you to Dr. John Kane.
Thanks very much. Thank you for inviting me to join you all this evening, and I appreciate your taking the time. So the topic that we have today is a broad one, adherence, and there are many different dimensions to this, and I'm going to try to cover some of the territory. We'll have time for questions after the second lecture. So I think first of all, we need to talk about diagnosis and the importance of that. When we prescribe medication, it's for a specific indication. And a lot of research goes into determining whether or not a medicine is effective in alleviating the signs and symptoms of a particular illness. So it's important that we understand the importance of diagnosis in that context. And I know there are some people who have difficulty either accepting the diagnosis, or they may not feel that they're ill in the first place. And in that situation, I think we have to talk about what is impacting someone's life, someone's functioning. Are they able to do the things that they want to do? Are there problems that are interfering with their ability to do what they want to do? And can we help in some way address those problems, even independent of whether or not it's associated with a particular diagnosis? We hope that over time, and particularly with appropriate treatment, that people can better understand and better accept the nature of their illness and the appropriateness of treatment. I think it's very important that when we are patients interacting with our providers, whether they be MDs or psychologists or social workers, it's very important that we can be as open and as clear as possible in the signs and symptoms that we're experiencing, the problems that we're having. It's really important that we are completely open and completely honest about those issues. And that applies to side effects as well. I mean, some people may feel uncomfortable talking about certain types of side effects. Let's say they involve sexual functioning or other aspects that people might feel embarrassed about. So it's really important that we have really full and open communication with the people treating us so that they can understand both how we feel and what we're experiencing in relation to the treatment that's being provided. How do we know when a medicine is effective? Well, we do studies, we do clinical trials, and the Food and Drug Administration has certain rules and regulations that they apply when a new drug is being developed. And those requirements are quite extensive in terms of not just efficacy, but also safety. But that means that we have medicines that have been approved by the Food and Drug Administration for a specific indication. That also gives us some information about dosage. But we have to remember that there are individual differences, and that one person might respond to a particular dose, another person might respond to a different dose. And sometimes that changes during the course of one's illness. It's important that we are aware of potential adverse effects. Some adverse effects are common. Other adverse effects might be very rare. But overall, we have to be considering the benefits and the risks of a particular medication. It's very unusual to have a medication that is absolutely free of side effects. So we have to, I think, accept that reality that medicines, if they are effective in helping us with our condition, that there's a possibility that they may be associated with certain side effects. And we want to work with our treating clinicians to try to minimize those side effects, prevent those side effects, or manage them in the best way that we can. One question that frequently comes up in the treatment of schizophrenia is, can medications be stopped? And we're going to come back to that issue in a few minutes. So when we use a medication to treat the signs and symptoms associated with schizophrenia, we go through different phases of treatment. Sometimes people are in the hospital when they're acutely ill, and they might start receiving medication. But then as they improve, they're going to leave the hospital and hopefully spend as much time out of the hospital as possible and work with the clinical team to try to prevent a relapse or a rehospitalization. And that's where maintenance medication becomes very important. And what do we mean by maintenance medication? Well, we're really talking about staying on the medication that's helped us get better in order to prevent a relapse or a rehospitalization. And illnesses like schizophrenia, bipolar disorder, recurrent depression are associated with some risk of relapse if we stop medication. So even when someone is feeling relatively well, that they've really recovered from the acute symptoms that may have been associated with a hospitalization, it still can be very important to continue to take medication. And I think this is a difficult thing for many of us to accept. You know, if I'm feeling well, why do I need to take medication? Well, in this situation, it's really preventive. It's prophylactic. The idea is that we want to stay well. The impact of relapse can be quite significant for many people, not just leading to a hospitalization, but interfering with functioning. When we work very hard to achieve certain goals, like getting back to work or back to school, establishing new friendships, et cetera, if we have an episode of psychosis, that can really interfere with a lot of the progress that we've made. There are also data to suggest that if we do have a relapse, particularly when we stop taking medication, that when we go back on the medication in response to the relapse, that the medicine may not be as effective as it was previously. And that's one of the concerns about relapse, that it might diminish our responsiveness to the medication that had previously helped us. And there are studies that have shown that. So when we talk about adherence, and adherence is a problem in any illness, you know, whether we're talking about high blood pressure or diabetes or epilepsy or asthma, or even people who have had an organ transplant and need to take medicine to prevent their body from rejecting the organ. Even those people sometimes have difficulty taking the medicine the way they're supposed to, the way it's been prescribed. So when we consider any illness, we have to consider, you know, what is our commitment to the necessity to take the medication? Do we understand the reasons? Are we convinced that the medicine is important? And do we understand in what way it's important? So medicine is not going to change everything. I mean, in the case of schizophrenia, medicine can be helpful with certain signs and symptoms, but it's not necessarily going to cure the illness. It may not help us with some of the cognitive challenges that we may have, or it may not help us with some of the negative symptoms that we may have. So medicine can only do so much, and we have to understand what it can do and what it can't do, and not be frustrated by the fact that the medicine has not solved all of the problems. In addition, it's very important that people take advantage of other modalities of treatment. So not just medication, but also, you know, talk therapy, group therapy, peer counseling, social skills, returning supportive education, supportive employment, helping with returning to work or to school. So there are many different aspects of what we might call therapy that are very important in addition to medication. One model, you know, that we've worked very intensively with is called coordinated specialty care. or early intervention for people with schizophrenia. And that involves not just medication, but individual therapy, family psychoeducation, family therapy, supported employment, supportive education, really working with a team of people to help us recover, help us achieve some of the gains that we want to achieve. But medication is a very important component of that. And what we've seen in our studies and other people as well is that when someone with a diagnosis of schizophrenia stops taking their medication, the risk of relapse goes up substantially, perhaps fivefold, for example. So a very significant increase in the risk. And studies in recent years have also shown that it's hard to identify a point in time when it's safe to stop medicine. Even if someone's been well, excuse me, for several years, that doesn't necessarily mean that it's safe to stop medication completely. I mean, that's something you want to discuss with your prescriber. But I just want to share with you that the data that has been generated from a lot of research centers around the world suggests that it's not necessarily a good idea to stop medicine, even when we've been well for a while. We certainly want to use the lowest possible dose that is still efficacious. We want to minimize side effects, et cetera. And the side effects are one of the big challenges that we all have. Concern about adverse effects is often the reason that people stop medication. And sometimes those concerns begin to outweigh the concerns about having a relapse or having a return to the hospital. But that's something that we have to weigh. And as I said before, adherence is a challenge with any illness for many reasons. And we have to destigmatize non-adherence. You know, if someone has trouble taking medicine, that doesn't mean they're a bad person or a bad patient. It's really human nature. I mean, I think we all, I mean, I personally take 4 different medicines every day. And we have to figure out a way to kind of remind ourselves to do that. And it turns out that we're making a decision every day as to whether or not to take the medicine. And, you know, it may be that one day we're not in a good mood and we just don't feel like taking the medicine. Or another day we're visiting friends or relatives and staying overnight and we forgot to take our medicine with us. Or we didn't get our refill in time, or, you know, there are lots of things that can happen that might influence our medication taking. But one of the challenges is that we are making that decision every single day. You know, am I going to take the medicine or not? And that makes us vulnerable, I think, to maybe lapses in medication taking that can have consequences. So we need to think about that as well. But everyone needs to, I think, work on a plan for themselves to facilitate medication taking. You know, do I have reminders? So I have a plastic container that has each day of the week on it. And so I can open Monday and I have the medicine that I have to take, and I can open Tuesday, and also I can see that way whether I've taken it. I mean, maybe I forgot to take it, and in that case, it's still there. And there are a lot of other strategies that people develop. There are technologies now that actually can be connected to, you know, to the internet, and you can get a signal if you don't take your medicine. There are a lot of very sophisticated methods that we can use to monitor adherence. But the key thing is for us to be really committed and convinced that the medication is necessary, even if we're having side effects. And then for some people, there's a financial burden, and they have to also recognize that. And is it worth it for them to take the medicine if it's costing them something out of pocket? So that's another concern that we have to struggle with. But I just want to emphasize again that we need to destigmatize non-adherence in medication taking, because it's human nature not to want to take medicine, and we all struggle with that. So we have to accept it, that non-adherence happens, and the question is, what are we going to do about it? How do we deal with it? I think that one of the real options that people don't always take advantage of are the so-called time release medications, or the long-acting injectable medicines. And what that means is that a medicine can be given by injection, either into a muscle, or in some cases subcutaneously, and that medicine can last for 2 weeks, a month, 2 months, 3 months, and now even 6 months. So there are a variety of possibilities with these long-acting formulations for people to be really kind of safeguarded against missing medication, or having that daily decision, do I take it or not? And for many people, they found it to be very convenient to go into the clinic once a month or once every other month or what have you, to have an injection. And there are anxieties that people have about injections, and I think we should talk about those as well. And that is that some people feel if they're getting injections, they've lost their autonomy. They're no longer in control of themselves. And I think that's a misperception, because what we're trying to do here is not control the person, we're trying to control the illness. And if someone decides that they no longer want to take medicine, hopefully they're doing that in conjunction with the clinical team. But if they were to decide that, it just means that they don't get the next injection. They certainly can stop taking the medicine if they choose to do that. Some people have a fear of side effects, because they say to themselves, well, doctor, you said, that I could get this medicine once a month or once every other month. So doesn't that mean that you're giving me a huge dose if it's going to last such a long time? Well, but these are gradual release. The medicine is not released all at once. It's released gradually over time. So you're never getting more medicine than you would get if you were taking pills every day. The difference is you don't have to take pills every day. So there really are no more side effects with these time-release medications than there are with the oral medicines. And we've done studies, we've compared the same drug given orally, the same drug given via these long-acting injections, and we don't see a greater degree of side effects with the long-acting injections. Some people think that there's stigma associated with receiving injections like that. Does that mean that I'm sicker? Does that mean that I'm a bad patient? Does that mean that I'm a problem patient? No, it just means that, this is a way to take medicine. It's a way to ensure that you have the advantage of the medicine without having to worry about taking it every day. Some people, might be embarrassed. Let's say they have a roommate and they keep the medicine in the medicine cabinet, and they don't want their roommate to see that they're taking medicine. They might be embarrassed about that. If they go to the clinic and get an injection, that's confidential. No one sees that. No one knows about that. And it's done much less frequently. So there really, in my opinion, there shouldn't be any stigma associated with receiving injections. I think for the medicines that I take, none of them are available via long-acting injectable formulations. If there were, for me, that would be convenient. I would do that. In a way, I'd say that we're fortunate in psychiatry and in the treatment of schizophrenia that we actually have several different medicines that are available in these slow-release formulations. And as I implied earlier, there are different intervals. So someone can decide they want to take it every other week, once a month, once every other month, once every 3 months, and even once every 6 months. So there are a lot of options, as well as there being different actual medications. And then people worry about the pain and discomfort. associated with injections. Nobody likes to get injections. It does, it hurts a little bit. If the injections are given well, though, really doesn't hurt that much. And what I've found with patients is that, the first injection might hurt more than the second or third injection because you're much less anxious. After you've had a couple of injections, you're more relaxed, you're not as afraid of it, and it actually hurts less because you're less tense. But some people are afraid of injections. I think what I explain to the people that I work with is just try it. I mean, see how you feel, see how you react. It's often not as bad as you fear or as you expect. The other big challenge, and I've already alluded to this to some extent, is not understanding the ongoing need for medication. I feel better. I've been feeling better for a year. Why can't I stop my medicine? And that's where we look to data. We look to data from thousands and thousands of people around the world who've been studied in clinical trials or studied in what we call registries, where patients can be followed based on their medical records, and we can see whether or not they have a relapse or whether or not they're hospitalized. And so the data are pretty overwhelming in terms of there being a greater risk of relapse when we stop medication and compared to when we continue medication. The other thing that some people, I think, struggle with is sort of negative past experience. So if I was hospitalized and I was really, acutely ill and I didn't realize how ill I was, and maybe my family took me to the emergency room, and I was very agitated, I was very upset, and so one of the doctors treated me with an injection of a medicine, and that was a very unpleasant experience because I was feeling really upset, I was frightened, and then someone's giving me an injection sort of against my will in a way. So that left me with a very bad taste of injections. This is quite different, when we're talking about someone who's improved on medicine, and they're entering into the maintenance phase of treatment, which hopefully is going to go on for a period of time. Having an injection is a very different experience. It's something that it's shared decision making. It's something that we're doing with our consent and our desire. So it's very different from some of those negative experiences that some people have had in the past. So those are some of the objections that people have when we mention the long-acting formulations. The other thing I want to talk about is for the family members. So if I have a loved one who is suffering from schizophrenia and they have a relapse, an episode where they don't necessarily feel the need for treatment, or they're very agitated, and I have to try to get them to the hospital even against their will. In some cases, maybe the police are involved because someone has done something that's brought them to the attention of the police, and they're taken to a hospital. If that happens to a loved one of mine, I'm going to be very concerned about that happening again. I don't want that to happen again. So I'm going to be asking my loved one about taking medicine. Are you taking the medicine or not? And that becomes, I think, a source of conflict. It can certainly be, because my loved one might say, hey, I'm 30 years old, leave me alone. You don't have to ask me all the time if I'm taking my medicine. I'm a grown-up. But yet people have trouble taking medicine, as we discussed earlier. So it's certainly understandable for the family to be concerned. And if someone's receiving one of these timed release formulations, the family doesn't really have to worry about that, because they know that the person's gotten the medicine. And if the person doesn't get the injection, then it's clear to everybody that they're not going to have the benefit of the medicine. When people are taking pills, the clinical team or the family often doesn't really know what's happening. And let me give you an example of that. We did a study in my hospital where about 100 patients were brought to the emergency room in a state of, relapse. They were psychotic. They were experiencing, severe symptoms. And it's important at that point for the clinical team, and the family to know, well, did this person have a relapse because they stopped taking the medicine? Or did they have a relapse even though they were taking the medicine? Because that can happen. I want to emphasize that even if we're taking medicine regularly, it doesn't mean that we're never going to have a relapse. It means that the chances of a relapse are much, much lower. But sometimes there still can be a relapse. We're doing some research to try to understand why does that happen in some patients, but it can happen. So I want to make sure that we understand that. But getting back to the emergency room study, it's important for us to know whether someone relapsed because they stopped taking medicine or they relapsed despite taking the medicine, because that would tell us maybe the medicine wasn't working. Maybe we need to use a different medicine. So we, in this study, we basically asked the doctors in the emergency room to tell us whether they thought the patient was taking the medicine or not. At the same time, we did a blood level to measure the amount of drug in the person's system. And what we found is that the clinical team got it wrong in both directions. Not all the time, but in a significant percentage of patients, they thought that the patient wasn't taking the medicine when they actually were. And in a significant proportion of patients, they thought that the patient was taking the medicine and they actually weren't. So they got it wrong in both directions. And that just points out how difficult it can be for us to know for sure whether someone's taking their medicine. And what we rely on the individual to tell us, doctor, I haven't been taking my medicine. Doc, last week I missed 3 days of my medicine. We're not always told that. And not, sometimes it might be embarrassment, doc, I forgot to take my medicine. Now I'm embarrassed and whatever. Or it might be that I decided I didn't want to take it over the weekend because I went away with some friends and I didn't want to take my medicine. Lots of different reasons. But the reality is that doctors don't really know when patients are struggling with medication taking. And if someone's receiving these slow release formulations, it's pretty clear. I missed my injection, means I'm not getting the medicine. The clinical team, my family, whoever can try to, find out what happened. Let's do something about it. And the other advantage is that the medicine is not out of my system so quickly. Because I've had the injection, it's still going to be in my system somewhat. And it means that the clinical team or my family has time to act before it's completely out of my system, before I really become at risk for relapse. So that's another potential advantage. So what this is my personal opinion from the research that I've done and from the literature that I read. I think it's important that patients and families consider this option and talk to their clinical team about it. It should be shared decision-making. It should be, with knowledge about what are the different possibilities. There are different medicines. We talked about there being different injection intervals. There are different ways of giving the injection. In some cases, you need some oral supplementation initially, which is not a big deal, but in some cases you don't. So, but there are a variety of options, and I think that what I would like to see is that everyone is aware of those options, and those options are discussed. And what I've also seen is that doctors are not necessarily great at presenting some of the things that we've talked about, because they're busy, they don't have the time. I've heard doctors say to a patient, look, I really think that it would be great for you to take injections. And the patient says, doc, I don't like needles, and then that's the end of the conversation. It's dropped. And I think that's a mistake. I mean, I've worked with patients over the years where it's, we've had this conversation over a period of weeks or even months. And then, at some point the patient said, all right, I'll give it a try. And then, they really had a good experience with it. So it's something that I also think that the clinical team is at times at fault, for not presenting these options in a comprehensive way where people have time to ask questions and to think about it and come back again and discuss it, and also for the family to be involved. I've heard from lots of families that, gee, I didn't know about this. No one told me that this was an option, because, I, as a family member, I think this would be very helpful. So those are some of the thoughts. I think the other challenge that some people have is, how do we stay on these injections? After a period of time, maybe my muscle is sore, or I feel, I've had enough injections, and that's something we have to talk about as well, because it's going to vary from individual to individual. But as you think about the injection interval getting longer and longer, then that can become less of a concern. If I get an injection every 3 months, that's 4 times a year. That's not a tremendous burden in terms of pain or discomfort or anything like that. We've talked about side effects. There's really no difference there. So I just want to reiterate that adherence, challenges with adherence. Adherence is very important. Obviously, a lot of time and effort and expense has gone into developing medicines and proving that they work. And when they're prescribed, I mean, they're prescribed for a reason. We expect them to be helpful. It's a shame if we don't take them. And we have to understand why does that happen? It doesn't mean the person's a bad patient or a bad person. It's human nature. So we really have to destigmatize non-adherence and be able to talk about it. I don't even like the term non-adherence. It sounds bad. It's like non-adherence. We haven't come up with a better term, but it's just a challenge in taking medication, and we have to be open and honest about that. And it's something to be embarrassed about. Figure out, okay, how can we deal with this? How can we address it? And we've talked about ways of doing that. It changes over time also. There are some people who early in the illness are absolutely opposed to taking medicine, but once they've had a couple of relapses, they say to themselves, well, maybe I really do need to take the medicine and try to benefit from it. We also have to accept the reality of side effects, that medicines are going to have some side effects, but we want to minimize them. We want to work with our provider to, if we can, to prevent them. But if we experience side effects, we want to be honest about it. We want to work with our provider to try to manage the side effects as best we can. Sometimes we have to change it to a different medicine, or lower the dose, or sometimes we might need another medicine to actually help us get over the side effect. Many drugs are associated with weight gain, for example. There are new medicines now that are being used to help with weight gain. So, I mean, there are a lot of different issues that are going to vary from person to person and from medicine to medicine, and we need to take all of those things into consideration. But to me, the bottom line is that medicine is very important in helping us stay well and prevent the relapse or hospitalization, to enable us to work on recovery with some of the other modalities that we talked about. And it takes time also, right, to recover from something that's very challenging. But we need to try to keep ourselves well in order to do that. So I'm going to stop there, and we will have time for some questions later on. And I think Max Gutman is going to share some of his perspectives with us, and then we'll have a time for questions. So thanks very much.
Hello, everyone. My name is Max Gutman. So I'm a licensed clinical social worker. I have a private practice that specializes in the treatment of, just about a whole range of mental health diagnoses, but specifically as a clinician, I own and operate the practice. We also have peer work too. Consider myself a peer. So I have my schizophrenia diagnosis, speaking of peer work, was when I was 21. I was in my last semester of college in upstate New York, and I got very, very sick. I know we don't always think of mental health and mental illness as a sickness. It felt sick. It was awful. Let's just say it was an awful experience. I did not like who I was. I didn't like where I was. I was in a state hospital. It was just very, very bad. I was dealing with a lot, all sorts of symptoms, all sorts of everything. The world was a radically different place. So, when framing this conversation about adherence and LAIs, I just want to just say that from the peer perspective, from someone living with a mental health diagnosis, it offers help. I like to think of an LAI as a tool that offers help. And when people are seeking mental health treatment, generally they're looking for a change. As a therapist myself, I know we're change makers. We're helping people make that change. So specifically, I think of medications, which, if you believe in medication, right, it's there, it's created with all that research to help you as a tool. It's there to manage symptoms and support stability. So the thing about pills versus an injection, right? I wasn't given a choice. So when I was in the state hospital getting discharged years ago, it was sort of said, you're going to start this injection. It was only 2 weeks at a time. It wasn't long acting. Okay. Every 2 weeks I'd show up for my injection. But that was presented as my discharge plan. It wasn't done the right way. That's why we're here. We're here to talk about better ways of presenting LAIs to family members, as either as a clinician or a friend or ally. But I wasn't afforded that option. Thank God I was introduced to LAIs and injections years ago, because the fact that I was introduced to this intervention so early on in my recovery has allowed me to stay recovered over time, and really not have had a significant relapse in 15 years. It's because I was given this level of care. We like to think a level of care, inpatient, whatever, level of care, level of assistance, level of insight, whatever it was that I was given as a tool. And this LAI is a tool. It's a tremendous tool, because it allows people to not have to think about taking pills every day, but more often, you're not giving mental space to stuff that you don't need to think about. When you have a schizophrenia diagnosis, you've got a lot of stuff going on. A lot. This problem, that problem, millions of problems you got to solve. Okay. Do you really need to be thinking about taking your pill every day? Where am I going to take my pill? Relapse. All the things that go around with getting pills and getting those refills. It's a lot to think about. Okay. LAIs, they offer peace of mind, continuous support. It's always with you. You get a shot, 2 months, 3 months, it's there. It's not going away. You don't need to think about seeking the help because you're already getting it. Okay? It provides stability. What do I mean by being stable? That's a clinical word. In my opinion, it means not having a crisis from week to week. It means when I'm in therapy with my therapist, I can talk about my real goals, not issues about medication. Am I taking my meds? Am I not? Is my therapist attributing my behavior now to not taking my med and not really listening to what I'm saying? Because I do believe that when medication and questions of medication adherence enter the family conversation or the therapy room, people really stop paying attention to what's really going on. They're thinking about something else. They're not really listening to their loved one, their family member, the person living with the disorder. They're in the suspicious mode. When you're questioning, you're not listening. So that's a problem for me. So early on, when I saw that my family can no longer say, "You can take your meds," or friends can say whatever, that possibility of having that conversation never amounted to anything. We never had to have it because I was always on an LAI. Okay, so medication was never even discussed. And truly, when you're prescribed an LAI, right, and they found the medication that works for you, that will be the medication that you take, right? Think about it that way. You're on a heading. You're on a projected course of treatment. You're not switching meds from month to month. This med works. Does that med work next month? I don't know. Maybe it was better 3 months ago. No, you're on a heading. You're on a path. You're getting used to how this medication feels in your body, right? And adjust your thinking, your planning, your whole mental way of going about things and how you handle the world, your behavior. You're thinking about it all the time, and you're not thinking about what needs to change. You're thinking about how you're going to make it work, because who you are now is going to be who you are a week later and 2 weeks later. You're not going to relapse as quickly. You're not going to be at risk of relapse. People won't question if you're relapsing. You see what I'm saying here? Okay, I just want to think about this, okay? Not just in terms of, a tool, something that's always with you, something that makes the therapy room more productive, something that makes you feel more empowered, because it is freedom. People say, oh, I'll lose my freedom. I question that. I push back on that. I say you gain freedom. You gain autonomy. You gain independence. You're not tied to a bottle of pills. And if you're at risk of homelessness, or you don't know where you're living next month, or if you have to pack up and move out of your friend's place, you don't have to worry about where your meds are. You don't have to worry about when the last time you took your meds are if you're out on a weekend. Please. I mean, I can talk all day about this. I know I wasn't here to do that, but I want to think about some bigger issues before I wrap this up. In terms of, relapse, missing doses, something you'll never do with an LAI, okay? And when you relapse, as we all know, with schizophrenia specifically, you lose brain matter, you lose brain tissue. Now think about it this way. Let's say it's hard to solve your problems with this brain, but like at 100%. When you're at 75%, do you think you solve your problems better? When you have less brain matter, when your brain is more disordered, do you think those problems get solved easier, faster? No, you're going to make more mistakes. That's why you're more at risk of relapsing again and again when you stop taking your pills and stop adhering to your treatment. In the end, okay, it's about adhering to a course of treatment. The medication is a prescribed course of treatment from a psychiatrist or whoever is saying you need to take these pills. Why are you deviating from your plan? If you have a plan to say this is how it's going to work, why would you deviate from that or give the opportunity to? If you miss a dose, if you forget to take your pills, if you start questioning if I should take my pills or not, why would you deviate from the course of plan that says this is going to get me better? Seems a little foolhardy, if you ask me. But in the end, I heard a lot about, adherence, bad word. To be honest with you, adherence is a very important word. Adherence is muscle. It's a verb. It's a verb. You're doing something. You're adhering. You're sticking to a plan, as opposed to non-compliance when you're the object of not doing. Okay? There's a difference there. It's about owning your health, owning your treatment. Okay? Because if you're an action word, if you're doing, if you're involved in your care, all that stuff, you're more likely to continue doing it as opposed to the object of someone getting treatment, right? In the end, adherence is an important word. In not adhering, well, I think that is dangerous. I think that is problematic. Because unless you're going to make a really concerted course correction and speak with a doctor and know exactly what to do and have a plan B, plan C, stick to plan. This is a tough illness. A lot's going on. You need to be prepared and you need to be focused. And that's what an LII is, I think, in the end. It's being focused on your treatment and your health. And I fully recommend LAIs for the treatment of this disorder.
So with that, I want to thank everybody for being here. I think this was super informative. I hope you did too, and have a wonderful evening. Thank you, everybody.